I've been in this business for well over 40 years, and I've never experienced what started to happen to us in February. It really is still a most surreal feeling about where we've got to with this pandemic, and how it's affected not just the healthcare market, but all markets. The largest piece of business that we have in London is corporate healthcare. Who knows if people like BA and Kurt Geiger, all the rest, will in actual fact renew health insurance policies. So it's going to be a difficult period for us all going forward. And if we thought the 2007 recession was bad, this is going to be really, really difficult. So what happened with us? In February, most of the private hospitals were looking at business that was just falling away day by day. By the time it got to the end of February, the GPs were reporting no private patients requesting private healthcare in their surgeries. And I've talked to quite a few of them. The market by the first week in March was well and truly lost. So the private health operators, and I'm talking about Ireland because I do run a couple of hospitals over there for Goldman Sachs, and it's exactly the same. The business just disappeared, and so all of the private operators were just desperate to sign anything with the NHS that would, of course, keep them in a positive cash flow. Now, there's no point whatsoever in business having a big order book. Businesses become insolvent because of cash. So when you consider the Wellington, when I was running the Wellington, I needed to clear £7 million a month before I made a penny profit. So once you go for 4 to 6 weeks with no business, you are suddenly in a very serious and precarious insolvency position. With HCA, you would expect that the big sugar daddy back in the States would send them 50 million cash, and that would be the end of it. Unfortunately, America was facing exactly the same restrictions. So the Wellington, like all of these private hospitals, signed a deal at which no consultant had a say in and probably didn't know about. Over in Ireland, there are 600 independent full-time consultants in practice. 267 of those consultants are suing the private hospitals for loss of earnings because they have completely lost their livelihood and yet had no opportunity to affect that particular change. Whether or not that succeeds, but they've got Michael Mansfield advising them, and it may be fraught with and come to nothing because the private hospitals over there and here pretty well bankrupt. The real worry for the private hospital at the moment will be getting back into the market. So if you imagine when this thing suddenly turns off and the NHS have had enough of us, you've not got then to start private practice all over again. So on the Monday morning, the first case in the cath lab, you'll bill for services probably a day later, but you'll probably have to wait 6 to 8 weeks to be paid. Now that's going to eat away at cash. So the next precarious hurdle for the private hospitals is to try and get back to actually normal working. And I can say without a shadow of doubt, the industry will lose lots of players because people won't have the cash to wait 6 to 8 weeks to start being paid again. A lull in the business period whereby costs are just being paid and some hospitals are making a very tiny profit. But whether they'll be there post-COVID is another matter. Now, the academics in management talk about demand restart, and markets that have been extinguished as a private healthcare market, you need to have a pretty sassy attempt to get this market restarted again. So Mark and I were sat in front of John Ray this week, and I think, Mark, we probably frightened him to death. They're probably going to hang on until August with this NHS contract work, which will be the absolute death knell for consultant private practice. It's hard for people to continue now. It'll be even harder if we can't get back into regular work very soon. So the Wellington, like the rest of them, will hang on to these cost payments from the NHS until they have to really then let go. When they let go, where will that leave them? And where will that leave consultants? And it's not going to be easy at all. Bridging the gap to get back to normal will be tricky, and I'm not sure whether some of these private operators have a clue about what they're doing. The biggest mistake that was made was to turn over all of the private hospitals to the NHS. They could have left a measure of facility back for the private consultant to operate out of. There was no need at all to close the Platinum Medical Centre.
Absolutely.
These hospitals, and I've spoke to many now, and I've been involved with some, are empty. They are just not being utilised by the NHS. Places like the Wellington are probably the most heavily used. I think the South Building have a lot of breast cancer work in there. But when you look around and see what they did to consultant private practice, and you never had a voice in this, which is the annoying part in this whole equation. All you needed was a couple of beds on wards or wherever, maybe a floor at London Bridge, a floor at the Wellington, 10 beds in Harley Street Clinic, and some consulting space, and you could have continued to have practiced. But it's gone, and I've never seen a market extinguish in the way this happened. So in a similar way, the way the car industry is saying people will get out of the habit of buying new cars, people may well get out of the habit of using the private sector. Now, during some of my work over the last month or so, I found out from someone at the Department of Health that the NHS liked this feeling of having control over the private sector. And I never came across anyone that liked us anyway from the NHS. I was always very critical of the NHS, and that's maybe why that was the case. But they have a plan to try and buy private hospitals linked to an NHS trust hospital, and probably linked to a university if that's involved, and buy in very much a fire sale a private hospital. And blow me, 2 weeks ago, we heard, coming out of the market, that Oxford University and its University Hospital of John Radcliffe had got together to make a bid to buy the Nuffield Manor Hospital in Oxford. The Manor Hospital in Oxford is about 85 beds. It's quite a fine private hospital. And they want to buy, so it's suffering like everyone else. And they want to buy that at a reduced cost and take it over. So the intention would be that they put their private patients from consultant practice into the manor. They'd move all of their waiting list initiative work into the manor. The doctors would be employed and would rotate through the John Radcliffe like any other consultant. If that comes off, it's the end of private practice in Oxford. So we've been left with a particular market that's very, very problematic. And for some of the consultants, life is really bad. You know, we all know people with 5 million mortgages and more, with 3 children and school fees and a couple of nice cars on the drive. It's all gone. Finished. You know, so what did consultants do wrong? Well, they weren't talked to in the first place. If you'd have been a strong player in the market, let's say you'd have had 1,000 members and you have a position in the market, you could pretty well bet that the hospitals, before they did all of this stuff, would probably want to check it out with you. Or, you know, so you have a say in the market. But unfortunately, private consultant practice and private GP practice is fractionated. And no matter what people do, consultants and GPs in private practice will largely do their own thing. So that's where we've got to. We really need urgently for consultants to have bed space, to have admission space. I think Mark and I were successful in managing to get outpatients opened in HCA. We now need to get some wards open specifically for private practice. Now, the NHS have stitched up the private hospitals, because if you were to open X number of beds in the Harley Street Clinic, for instance, you would have to declare the income from those private patients. The NHS will take 15% of that income and they'll pay you less on costs. So the bottom line is they don't want you to do that. They want you to hang on forever until such a point as they've had enough or they've entered the market and made some acquisitions. So I'm going to leave you with those thoughts. This is going to be a very difficult time to bring the market back. If the GPs are not seeing private patients in their rooms, you will never get to your private patients unless you can call every one of your existing patients, send them a letter, send them a note, send them an email to say you are now back in practice. Effectively, for the moment, leapfrogging the GP and getting straight to the root source of patients. The corporate hospitals won't do that for you. They don't quite care. And in fact, they don't quite get it that they've lost the market.
Right. So we, just in terms of Jeffrey will know what I mean, is that if the LCA sends out an email to its members saying, would you mind answering a few questions, we're lucky if we get 3 replies in a couple of weeks. So when Keith and I were thinking about this session and the issues were being raised, the committee took that on board and thought, well, why don't we do a survey of what the practice is currently? And this was in May the 15th to May the 22nd, the worst dip, if you like, of the market. We had a simple survey, Monkey. I know some of you took part. And we got 238 replies by the end of a weekend and 150 replies by the lunchtime that we actually sent out the survey. So that was a massive response. The majority, as you might expect, were surgeons. This was sort of, I just chose this quote. One of the things the survey did was allow people to express in the final question was, have you any other thoughts? And so this sort of summed up to me, I got 8 pages of A4 of thoughts from our membership about what they felt at this point. And the overwhelming feeling I felt was summed up by this quote, that the hospitals all cut us loose when they contracted themselves to the NHS. They prevented us from doing any work or managing our patients properly. And I had 8 pages of very similar type of comments that we'll be publishing. Helena, next slide. So the things that struck me was the rapidity and the participation. The comments demonstrated not only the professional, but also the personal impact of the pandemic. Essentially, all the consultants felt very badly let down by everybody, not just the hospitals, but their insurance companies, where they tried to reduce their premiums, the hospital providers, and also the private medical insurers. And we opened it to say what they were planning to do, and there was a heavy statements about many of them, either at the beginning or certainly at the end of their career, just saying it's not worth it anymore. We can't see any value in continuing. And that was striking both for the newish consultants as well as the later consultants. And we had a nice bell-shaped curve in terms of practice, in terms of between 1 and 40 years of practice. Next slide, Helena. So in terms of the discussion points from the surveys, it's quite clear that, I mean, when you go to talking about private practice, it's not a great political vote winner, and you don't get much sympathy as a private consultant. So the big focus has to always be on the plight of the patient. And there were lots of cases of people quoting patients drop without warning, access to care, prioritization and waiting times. The consultants dropped by the hospitals. The situation really was only being felt. As a group, we felt that the patients and the consultants were the only 2 people who were really suffering. And a lot of people were quoting at least 80% of their practices had disappeared. There was a lot of bad feeling about this NHS contract, and the overall sense was that everyone else was working in their best interests. And as Keith was hinting, there wasn't any consultant within those who answered the questionnaire who felt they had been involved at any level. And we were just discussing with FIPO last night, Richard had sent round, there was a Langbuson conference next month, or later this month, on restarting private practice. There's about 20 people invited. None of them are a hospital consultant in private practice. The only doctor is the GEP, who's the current chair of the Independent Doctors Federation. There is just no hope at the moment, and that you need sending us level 1, 2, 3, 4, 5 protocols about how difficult it will be to restart your practice. And in a sense, just demonstrating the obstacles to restarting is really not very helpful at the moment, that there's just nobody offering us any hope as a group of how we would get going.
Absolutely, Mark. I mean, I think we need to divide it into international and UK-based patients. So if I look at the international market first, which is actually the majority of my practice, I'm having to manage remotely Middle Eastern and African patients who will not be coming back in for the foreseeable future and have very poor healthcare at home. So from that point of view, I would say 80% of my practice has just disappeared with no guarantee of restarting. From the UK point of view, I think your point about the NHS and the service that we're going to be able to provide is very valid, and that I'm more optimistic that people will go to seek a primary care physician in the private sector. But if I can't offer the service to then refer into the secondary sector, it's a problem. There is virtually, I've had issues with getting people seen. I've had to send people who I would normally send to the private sector, one of whom got COVID and died, which wasn't great. I feel very pessimistic and not optimistic about how primary care is going to be built up. And if I don't have the support of being able to pick up the phone to my secondary care colleagues who can do face-to-face, then I don't see a future at the moment. I don't see it coming back anytime soon.
Keith, do you have any comment on the primary care angle, first of all? Because as we talked about, without patients going to see their GP, getting the tests done and getting referred in, it's difficult for us to generate the work from scratch.
Well, if I were operating a private hospital, without a doubt, I would spend quite a bit of money on a public relation and marketing plan for GPs in private practice, because unless you can start the industry at that level, as Lisa said, there's no chance it will come through into the secondary care level. Whether we can convince private hospital operators, when they're worried about their future and cash flow, to put 40 or 50,000 pounds in, because that's what it will need to regenerate that market back into the primary care sector, I'm unsure. All they want to do is to see well-heeled private patients coming into the hospital, for which they make a lot of money on, and consultants make a small amount of money on. And that's the model, and that's what they like. But on advising Goldman Sachs on their 2 assets in Ireland, I've actually convinced them that they need to have each one of those private hospitals starting now, before the thing comes back, starting now on a big marketing program on radio, on website redesign, on mail drops and all of that good stuff, to say, look, we're here. And unless some help is given, we won't see secondary referrals. Now, there is a glimmer of hope here. If we consider that somewhere there is a pent-up demand of patients waiting to come in hospital, I think that's a fairly good assumption. I'm looking at the sunny side now, the bright side of this. Then we might say that we would clear in 8 to 10 weeks all the stuff that Duncan may have in his practice that really needs to come through and be seen. If we can make that happen, and we can get to this magical 8 to 10 weeks in the restart, there could be an opportunity for waiting list initiative to come through in large volumes, because, as Mark said, you're back to 3-year waiting lists here. So it may be with some good volume NHS waiting list stuff that might see the private hospitals on a lifeline to be able to limp towards the end of the year. But it's all very nebulous at the moment. But if I was managing a private hospital, I'd certainly be wanting to look at public relations and marketing support for the GPs at that level, and everyone to say, look, we're here, we're back.
Keith, can I ask you, do you know what's happening in Germany? Because Germany is the international market is my biggest competitor, and I think for secondary care is also a big competitor. So do you know what's happening over there?
Well, they've started. They were smart. They did test and trace very early, didn't they? So they're up and running. They're back into the market. And Germany was always one of the big competitors for London inbound patients, because they're pretty smart. The hospitals are pretty slick. They've got some decent doctors. So I think they've started and they're back. It's difficult in Germany because, as you know, Germany is regionalised. It doesn't have a national anything. It doesn't have a national health service. They're all regionalised. And that's how they can move so quickly and be so nimble, because they don't have this wretched, huge, monopolistic NHS that's trying to do everything from the centre. And you know, we're just crippled by the lack of process on this. But so Germany are ahead of us.
Richard, as on behalf of FIPO, because I know you've been heavily involved this week as well, is there anything you want to add at this stage to what we've said so far, or do you think we've covered most of the issues you wanted to raise?
I think the main issue is selling the idea of what independent practice actually means for the overall healthcare in the country. Because without a viable independent sector, the NHS, which was already failing before COVID, is really going to fail. And I think that's the major selling point, that by having a robust independent sector, the NHS will actually be able to get back to doing reasonable job of what they're supposed to be doing. Waiting lists won't have become multiple years.
You make this point, Richard, that the NHS, with the private sector, of total healthcare in this practice. But I struggle with that message, because it's sort of encouraging the two-tier system that somehow we're offering better if you can pay for it. And I think at the moment that's a difficult public message to be giving out with the current NHS loving. We've discussed this week, haven't we?
I'm not suggesting necessarily that you will get better, but that if the independent sector is working, there will be much less stress on the NHS.
Yeah. So thank you, Keith. Thank you, everybody. I have a couple of points to make, Mark. I don't know if you mentioned this at the beginning. You mentioned FIPO. I wonder whether you could work with the Independent Doctors Federation, because there are hundreds of consultants who are members of that. I know Neil is the chairman. He's a GP. I think I have a consultants committee, even though I'm not on it. Next point, my spies tell me, I have spies as well in various places, that in London alone, there are probably 1 million NHS operative procedures that have been deferred. And around the country, it's many multiples. But of course, we have to bear in mind that when the NHS restarts, they're going to be running at half capacity, because these long gaps between operations that are now going to be mandated. So that 1 million operations has got to go somewhere. The next thing, I completely support your thing about cost effectiveness. So if I have to gown up and scrub up and put PPE up to put a scope in somebody's nose, which takes me 3 minutes, and then I've got to wait 30 minutes before the next one, with AXA paying £55 per scope, it's not worthwhile. I completely endorse what you said about the private indemnity cover, Medical Protection Society. It was worse than banging your head against a wall. It's banging your head against a wall with spikes sticking out. And then finally, might be contentious this point. For some of us who haven't done any operative procedures, since in my case, March the 20th, we're coming up to the 3-month mark. And there is a document from the Academy of Medical Royal Colleges that says if you have 3 months away from your skill set, you need a calibrated return to work. And I don't know how that's going to fit in, both for NHS surgeons who perhaps are not doing elective work, and certainly for people like myself who are full-time private. So those are my comments. I hope those are useful, Mark.
Well, I think the 3-month thing, I mean, as a non-surgeon, that sort of feeds into your medical legal work, I suspect, Tony. Anyway, so Jeffrey, do you go going around the room? Jeffrey?
Well, yes, thank you, Keith. I mean, it is very difficult. I mean, as far as GPs are concerned, and we appreciate Lisa and all the private GPs, but most of the patients are referred by NHS GPs in London. I'm not referring to the overseas market. And of course, they have to be brought into it. I mean, everything's going to be governed by the COVID regulations. And as you say, if these continue, it's going to make practice extremely difficult. So I think, you know, we're bound by that. There will be waiting list initiatives. As Tony said, there's a big backlog. Of course there is. And it may well be that, as Keith and others have suggested with the Manor Hospital in Oxford, the way to take up that slack will be, as you said, Keith, to put waiting list initiatives into the private hospitals. And there'll be many doctors who are quite happy to do that work. But it's not really the private practice. And of course, Mark, you hinted about the PR issues. You know, as I've said to you before, the National Health Service is the new religion of the country. We've always, in private practice, had a bit of a sort of shady side to it, or an aspect, right, that goes back for hundreds of years. So you have to be very careful how you handle the PR aspect. And again, it's going to be very, very delicate how you do that. And you should be very conscious of it, because there are plenty of people out there from CHPI and many other groups who would be very happy to privatize or nationalize the private hospitals. I think there is quite a big problem there. I would like Keith to enlarge on that. So as far as consultant organisation is concerned, I mean, I think the IDF is fine, but I think FIPA is the way this should be managed, and Richard's doing a grand job. I congratulate him on all the issues that he's done so far, and you might enlighten us a bit more about how the insurers reacted. Thank you.
Tony, just coming back to you a second, politically, I mean, we're not getting, I mean, I suspect it's just as the Conservative Party are just not prepared to come out and support private practice for political reasons. Is that just what we're struggling with on that point?
I think so.
Okay. Keith, did you have any comments?
I spoke to the medical director of, is it the Independent Healthcare Providers Network or whatever they've got some grand name. I also had a chat with the chief executive of the SPA Hospital Group, which are obviously not really in London. And I think the SPA Group have got no concept, a bit like John Ray, of what's happening in the future. And the Independent Healthcare Providers Network, they're just sort of working on the basis of baby steps forward. So, you know, as you know, NHS in London have said you can do stuff after 5 p.m. Monday to Friday and at weekends. But there's no sort of sense of the seriousness for those of us who are working in the independent sector, because we're invisible, we're not important.
Yeah.
Keith, sorry,
Mark.
So who's Richard? Do you want to come back to?
Yeah, I just want to say that we sent a letter this morning from FIPO to David Hare at IHPN, and this was in fact a suggestion that had been made by the PMIs when we had our meeting with them, to try and get some professional representation on the organisation of how phase 2 of the NHS contract is actually going to be managed. So I've yet to obviously get a reply from that, because the letter has only gone out today. But I mean, it does seem extraordinary that there is no professional representation in this whatsoever. Especially when you think at the moment that the NHS hospitals are empty, apart from what they're doing with COVID and a few emergencies. There's nothing else going on there. I was talking to a colleague the other day who said at Wexham Park Hospital in my area, the wards are just empty. They're not doing anything. So the fact that the private hospitals have got empty beds is even more ridiculous, because those beds could easily be used for independent patients.
Keith, did you want to come back on anything that you've heard?
Yeah.
Or?
I think, look, the smart money would have been on private hospital operators reserving hospitals or beds or whatever, and talking to the consultants and bringing the consultant into a package that would be workable going forward. The unfortunate thing these days about private hospitals is that they tend not to see the consultants as the people who bring income into the hospital. They tend to be seen as difficult individuals that won't toe the line. Now look, if you want to get a patient now into any private hospital, look at the tiers of management decision making that you have to go through. That's the truth of the matter. None of the consultant bodies or consultant individuals were consulted on any of this yet their practice and their income and livelihoods has been affected by it. And I think we have to be a bit brave now and stand up. Mainly the full-time independent consultants now have a voice, because people are saying, actually, they have been disenfranchised throughout all of this, and we thought it was just the hospitals that was bad. So this is the biggest challenge, I think, since private practice ever came into being. So I think we have to get around these corporations. We have to say to them, we want you to put money into restarting the market. We want you to support us. You know, there's no reason why there should be any charges for the first 3 months or 6 months on all outpatient rent. If they all do it as an industry, then it's not an inducement.
So I just want to thank Keith ever so much again for the time and trouble he's taken in sort of doing this slightly unorthodox presentation. And thank you everyone for signing up and listening in. And I hope it's been of some value. It's allowed us to wear some thoughts and to take that forward. We're trying to Project Restart for private practice.